Hello, good afternoon, everyone. We're so happy to see you today. My name is Allison Elsner, and I'm the CEO of the San Bernardino County Medical Society. And we are very happy to be presenting our 2025-26 Medi-Cal series. And this is our first session today on December 10th, which is an overview and current landscapes on how can physician practices get prepared now for the upcoming changes with Medi-Cal enrollment. We will be having 4 other sessions after this, and those will take place in January, February, and 2 of those in March with our other partners. This is a collaborative effort between San Bernardino County Medical Society, Riverside County Medical Association, Inland Empire Health Plan, who has been very instrumental in helping us put this together, and the Hospital Association of Southern California. Before we introduce our speakers, I'd like to remind everyone, if you can just keep yourselves on mute while we go through the presentations here. And if you have any questions, we would very much appreciate if you could put those into the chat feature on Zoom, and or when we're finished with the presentations, we will go through the questions, or you can raise your hand on Zoom and we'll take your questions that way. So let's go ahead and get started so we can delve into this awesome information here today. We're very excited to welcome our 2 featured presenters. Thomas Pham is Vice President of Strategy for Inland Empire Health Plan. Thomas understands what it means to grow up in a challenging environment. He also knows the incredible impact that comes when individuals and families see hope on the horizon. He's made it his life's work to help every resident of the Inland Empire find their path to a healthy and joyful life. As the Vice President of Strategy, Thomas develops and executes IEHP's strategy system to advance the organization's mission and achieve their bold 2030 vision. He leads the creation and implementation of IEHP's multi-year strategic plan and ensures the health of the entire strategy portfolio. He's responsible for the research of internal and external insights that help accelerate the organization's success and help establish new strategic business opportunities. In addition, he leads the membership growth strategy, including new enrollment and member retention. He's constantly seeking new ways to expand IEHP's ability to serve the IE communities. He received a master's in public health with an emphasis in healthcare administration from Loma Linda University. Oops, sorry, my screen kicked off here. And a bachelor's degree from the University of California, Los Angeles. Thomas is blessed with a beautiful family and loves exploring our great nation and the world. Welcome, Thomas. And we're also excited to welcome Shalaun Jones, Director of Member Eligibility Strategy for Inland Empire Health Plan. Shalaun Jones has a connection to people, process, and technology, which allows her to develop effective strategies to ensure members of our communities with limited resources to get the housing, food, and medical support they need. Shalaun has 27 years of experience in social service programs, specifically CalWorks, CalFresh, and Medi-Cal, working with families residing in Riverside and San Bernardino counties. Shalaun's experience allows her to further her work and increase the opportunities for collaboration. As IEHP's Director of Member Eligibility, Shalaun partners with counties and care providers to bring awareness and solutions to barriers in retaining Medi-Cal eligibility and accessing care. So at this point, we're really happy to turn this over to Thomas Pham, and we look forward to hearing from you, Thomas.
Right. So thank you, Allison, for your kind introduction. And before we go into the presentation, and Shalaun going to show the presentation of shortly here, I really be grateful to have opportunity here with Shalaun and present some of the changes come to Medi-Cal in 2026 and 2027 that have tremendous impact to our region. First of all, I want to give a high shout out to our provider community, Allison, because in 2025 we're wrapping up, in December now, and we reflecting back and see what see the impact of the changes in 2025 to the Medi-Cal eligibility. There are so many significant change in 2025. From the state required the reinstitution of the Medi-Cal redetermination and all the public health emergency flexibility that the state has been using during the public health emergency to ensure the member continue that eligibility. Those flexibilities are gone, right, in 2025. So at the state level, they forecast that by end of 2025, statewide enrollment will be reduced by 4% or higher. And that's what they really observe and see, experience across the state, right? Like LA, Orange County experience about 4% drop of the enrollment. And the reason I want to call out because I want to give huge kudos to our provider community, our community partner, our county partnership, as well as the work the Shalaun team is doing in that. Our county, our two county, we're the only one that have disenrollment of 1%. So all the county disenrollment rate during the 2025 is 4 times higher than our two county here. It's just amazing that we appreciate the partnership from the provider community because Shalaun team every day receiving the referral from your office, you sending your patient over, or when your patient checking in to see you, you actually remind them to renew their Medi-Cal. And it give me a goosebump whenever I share this story at the local health plan level and at the DHCS as well. And they always make reference to our two county and the partnership between IHP and the provider community, partnership between IHP and the county and the community-based organization that result in lower disenrollment rate than anywhere else in the state. So that I want to kick that off with going to the presentation because 2025 eligibility change in 2025 is significant. Those change continue carry on into the 26 and 27. Not only that, there are more change come into Medi-Cal eligibility in 26 and 27 as well. So our work in front of us, our partnership in front of us, it require even more, right? The stronger partnership between, the provider community and the plan. So with that, Shalaun, next slide, please. So the objective of the today, so I hope there is a more conversation dialogue between, Shalaun and I with you, and feel free to ask questions throughout at the end of the presentation. The objective is that, we would want to create a shared understanding of what changes in 26 and 27 with you. What it means to you and your patient. Don't change what it means to you and your patient. How IHP prepare? How do we prepare now and with the county and you? And identify, we will share with you some of the tools that help you to support your patient in the redetermination process. So next slide, please. So what are those changes? Next slide, Shalaun. So I borrowed this slide from our friend of Department of Healthcare Services. It highlights the changes from the HR1. And there are many changes in here, but particularly for this section, I only focus on eligibility domain. So next slide, please, Shalaun. So for eligibility side from the federal level, federal policy change, that's starting January 1, 2027. The federal will mandate work requirement for Medi-Cal expansion adult who age 19 to 64. And of course, the state have an option to delay, but look like California, the Department of Healthcare Service, very clear that we will not get extension. I think we get so much love from the feds. So I don't think we're gonna get any extension there. So the state is at the full force, in the full speed to get ready for January 1, 2027. So it will require, remember, it's only for Medi-Cal expansion adult, Medi-Cal expansion adult. Um, and on top of that, on January 1, 2027, for that same population, not only it require the work requirement, but it also required that population to renew their Medi-Cal every 6 months instead of every 12 months. So that population will get hit with two extra requirements, the work requirement and the semi-annual requirement as well. So that's huge. That's significant. And another element in, that would be effective January 2027 as well is that when an individual apply for Medi-Cal, usually, and if the Medi-Cal approved, it's usually retro back 3 months because some of the service they get during those, 3 months, it would be covered. So now it will be shortening that time window. So for the adult population, it's only 1 month. And for the kid, it will be 2 months. So in a way, they shorten the retroactive window that that population will receive Medi-Cal. So that's really a big change. And coming to, looking forward to 2028 that you see in there, it will require some co-payment for the Medi-Cal expansion, I know as well. So that population will continue get more requirement at the time go by. So next slide, please, Shalaun. Um, and what other change coming down to, in 2026, and then we go reverse the time here. So I love how we play in this. So 27, so we go back a couple months, October 2026, that the important thing is that the federal redefine who eligible for Medi-Cal. So some of the population today, they are getting Medi-Cal and the state getting the federal dollar match as well. But starting October 26th, some of that population will shift to the state-funded Medi-Cal only. So what the Fed tried to do is shift the dollar back into the state, right? Shift the cost back into the state. So state will pick up the entire cost for the following population, the refugee, the asylees, and certain non-citizen group. So before this group getting a full match from the federal, 50-50 match. Going October 2026, the state will pick up the entire tab. So that put more pressure to the state budget coming in 2026, 2027. Next slide, please. Shalaun, so this is another view, like we try to map it out of HR1 and also the Medi-Cal eligibility change that coming from the state policy as well. So the big one right now that I mentioned about the 2025 that will continue carry into 2026 to 27 is all the flexibility that the state have been using during the public health emergency to help keep member eligible, keep member on the Medi-Cal. Those flexibility is gone. So that will continue have significant impact to the enrollment. And from the state policy side as well is coming up next month around the corner, January 2026, that the undocumented population that currently receive full Medi-Cal, full scope Medi-Cal today, the adult population will able to keep their Medi-Cal if they currently enroll in Medi-Cal and they are successfully renewing their Medi-Cal. So the 19 plus adult will be able to keep, but only if they successfully renew their Medi-Cal. However, for the new UIS adult, that folk who are brand new to Medi-Cal, that never had Medi-Cal before, they will no longer eligible for Medi-Cal. So I'm just pausing there that the difference is that if they currently enroll in Medi-Cal, they can keep that, but only if they successfully renew their Medi-Cal. The state frees the enrollment for any new. So there's no change. There's no change for the kid, the undocumented kid. So kid under 19 will continue to apply for Medi-Cal or will continue to renew. So this applies for adult. So giving you a perspective of the UIS population that IHB cover. So IHB cover about 150,000 UIS. So UIS stand for unsatisfactory immigration status. So undocumented population. So we cover about a little more than 150,000. And of those, 130,000 are adult. So those 130,000 adult, UIS adult, this is their chance. When they renew, and when they up for the renew, they have to, that's their chance to keep the Medi-Cal. The minute they fell off the Medi-Cal because they don't complete their redetermination process, they will not be able to get back on. So this even more critical this coming year, for the UIS adult that who really want to be on Medi-Cal and get the healthcare coverage, they have to renew their Medi-Cal. So going to the 27, we already talked about that the work requirement, the 6-month redetermination, the retroactive coverage changes to impact of 2027, and then going to the July 2027, the UIS population who currently enroll in Medi-Cal, there will be a monthly premium. There will be a $30 monthly premium, but that won't be effective until July 2027. What do it mean, all that, to our region? So if we walk back into the 2025 with all the PHE flexibility aspiration, that impact our the enrollment side. So with the PHE flexibility, the county had been able to successfully auto-renew about 65 to 70% of the population. When the PHE flexibility expired in early 2025, that auto-renew mean, they're able to get the data from the federal, they're able to give some flexibility, the time, the document and all that post the PHE expiration, the auto-renew, it dropped to 40% only. So from 65, 70%, the auto renew is only 40%. What it means is that 60% of population have to go through the manual renew process. And the manual renew process, that means there will be a demographic issue that the mail have to get to their mailbox. And if they move, they may not get that packet. So the goal is to get more auto renewal. But with the PHE flexibility expire, that auto renew has been dropped to 40%. So it's super critical for us to remind those population to submit their packet. So going to the impact of 2026, mostly to the UAS adult population. So it's about 100,000 member, more than 100,000 member are at risk because if they don't renew, they're gonna fall off. And for the work requirement and the semi-annual report, it will impact about more than 600,000 Medi-Cal member in our region here. So next slide, Shalaun. So basing on all those kind of things, so we at IHB we forecast how does that impact IHB. So I just covered the 2025. We have been very fortunate with the relationship that we have with you, the provider community and the county, and the work, the outreach, the effective outreach strategy that we've done. We see our membership stabilize at 1.5, and you saw that we only lost 1%. That 4 times lower than everybody else at the state. Going to 2026, it's not going to be easy. It will be more, the eligibility will become more challenged. So we forecast that in 2026, IHB will lose about 100,000 lives. So from, to 15, 20,000 lives in 2025, we project that we're going to lose about 100,000 lives in 2026. Go to the 2027 because the impact of the work requirement and the semi-annual report and the retroactive on Medi-Cal, those changes are huge. So we forecast that we will lose another 150,000 member. So why I want to share with you kind of the membership forecast, the membership impact here. It just it's a time that where it requires the partnership even more and require more focus on the strategy that we will use to navigate and to minimize the impact. Because I believe that with the strong partnership we have today with you all and with the county and CBO, this worst case scenario will not materialize. I think that we will be able to minimize the 250,000 member loss in the next 2 years. I think we will minimize the damage with the partnership we have today. So next slide, Shalaun. So I want to share with you kind of a high level four strategy that we are um, actively working now. The first one is policy advocacy. So IHB is at the table. I'm part of the DHCS technical work group to develop the policy on the work requirement, the semi-annual report, the PHE flexibility. Because this DHCS bring together a small group that help kind of a sounding board for us for the state to develop the policy as well as the guidance for the county across, the state of California on the implementation of the HR1 and the whole U.S. population. So, and our own county as well, we are very fortunate. Our own two county are at the table, at the work group table that the HCS has as well to continue advocate for more flexibility in the implementation. We are advocate more automation. We are advocating for streamline. For example, semi-annual report instead of 20, 30 pages, can we do 10 can we do like 1 or 2 pages? So we are actively advocating, and then our CEO and at the the advisor to the ACS director as well to advocate from that standpoint. So policy advocacy is very important. So fortunately, we are at the table to set up the policy at the get-go. Training side that from the county perspective that provide training to their eligible worker, Shalaun team. We are training the team. We're training across the organization on the changes and the tool that Shalaun and the team developed to you to navigate this. And operation readiness. We are working with the county. We are working very closely with the county on their operation readiness because eligibility determination or redetermination or work requirement it all happen at the county. It's not at the health plan. It's right. So we hand on hand with the county and our partnership with the county, I would say, we are very proud of that partnership. And the ACS always you the partnership that we have with the county, kind of at the stand of the state, and encourage all the county to follow. So we have the data sharing. So data sharing with the county. We're the only one that have like every month the county share with us the data on IHB member who have to go through the manual redetermination process. No one has that. So they share that with us. And also every week, kind of nice that they share with us an updated file. They say of those members that go into your manual redetermination, who actually successfully passed, who actually successfully renewed, who still have not turned in the application yet, who turned in but application incomplete, who got denied, who stays still waiting for extra information from you, though information that we can focus on target one-on-one to IHB member who need to complete that process. So the data sharing with the county, I think it's just phenomenal. And Shalaun will share with you later on of how do we use that data and we share that with you, our provider partner. because all those data is valuable to you today. And Shalaun will share with you how to navigate that. Member outreach side. So we have a coordinated effort with the county. So as you know, a member get the notice from Department of Healthcare Services. They get notice from the county. There are multiple notice, like letter, text, phone call, and all that. So we don't want to bombard our member with a lot of junk mail, a lot of like overwhelmed with information they don't know what to do. So we work closely with the county to have the cadence of communication. So our communication is supplement, like support the county in getting our member to renew. So Shalon gonna go very in depth with you what we are using today, and she will share with you kind of some of the asks or some of the requests that we would like your support. So with that, I will pass it to you, Shalon, for your part here.
Thank you, Thomas. I am navigating slides and okay. So as Thomas mentioned, there are a lot of policy changes coming out of that has been impacting our particular population. As we are coming out of the PHE expiration, it's important for us to really understand what the behaviors of our membership actually is and how this process could potentially impact them. As Thomas mentioned, there are three key areas here that our members may be thinking about, or your patients may be thinking about as these changes are forthcoming. So, one area is we want to make sure that we are messaging to patients and members that are going through the renewal process for the very first time. Also, as Thomas mentioned, which has been historical with the population, is really how to keep their information updated, not just with the plan, not just with their doctor, but also with the county as well, to ensure that the packets and the information that they are receiving is timely and that they can also act upon it timely. And then finally, with the enrollment freeze that Thomas mentioned, it's important for us to be intentional about our messaging and offer clear communication to the UIS population to ensure they understand the changes. And more than ever, it's important for them to retain their Medi-Cal. So the state's top goal is to really minimize beneficiary burden and promote continuity of coverage for the Medi-Cal beneficiaries. The state's Department of Healthcare Services has implemented a communication campaign to reach beneficiaries with messaging across multiple channels using trusted partners like the plans as well as the provider community. This platform that they use to communicate this messaging is the DHCS Coverage Ambassadors campaign. Ambassadors are trusted messengers made up of diverse organizations that can reach beneficiaries in a variety of appropriate ways. As ambassadors, we can connect with Medi-Cal beneficiaries with targeted and impactful communication that can be used to get the word out as we engage with them through social media, call centers, in person, or online. The DHCS Coverage Ambassador campaign is really centered around education, engagement, and offering and providing consistency. So, based upon that sort of premise, it was important for IEHP to really think through tactics and strategies for awareness in general as it relates to retention, because all of our members need to be retained. But really, what is key messaging for the UIS population? So, IEHP has a very robust marketing approach centered around retention. Some of the tactics are listed on the screen here, and as a part of this work, IEHP is also finalizing a provider communication toolkit, which will provide communication resources designed to support you as well. So, on top of all of the member-facing messaging, our CBO and really boots on the ground and grassroots activities centered around messaging and support of the member, we also have an area and many touch points, especially with you all, to conduct that outreach and support. The messaging with the communication toolkit will be ready for use and can be used across multiple platforms and design, and takes both a broad and focused audience sort of approach to that messaging. So the toolkit will include information that DHCS has put together in an FAQ, as well as materials that IEHP has put together that can be shared. As a best practice, you should use the messaging that is provided in the toolkit. Offer resources in the preferred languages. So the toolkit messaging that can be shared in your offices will include all the four threshold languages. And it will also provide appropriate county information as needed, as well as ways to get in contact with IEHP for support. And so there will be reminders at every contact with each beneficiary. So, renewal and how you can support. So there's four simple ways that you can support your patients through this process. Again, we are emphasizing 2026 is really the year to lean into retention and keeping coverage for the UIS population, so they are not at risk in limited services if they are disenrolled. And so it's important for providers to advise members to keep their contact information current. Again, not just in the facilities where they are where care is being provided, but also with the plan as well as with the counties. As Thomas was mentioning in our data sharing with our county partners, as members are calling into IEHP and they're making us aware of address changes or phone number updates, we are also sharing that information with our counties, so that way they can make those updates to ensure that the packet goes out to the right address, as well as the dedicated phone number if they need to reach the member. Also, it's important for our providers to advise members to complete the annual eligibility redetermination process in its entirety. This is looking out for communication from the county, ensuring that the packet is complete. And the process is not complete until they receive a notice of action saying their Medi-Cal has been approved for another year. So it's important for them to register for Benefits Cal accounts. It's very important that they're checking their mail often for those updates from the county. And for IEHP members, we have a dedicated eligibility team that is ready and on standby to actually walk its members through the redetermination process. My team is designed to actually assist the member and can submit the renewal on a member's behalf. We also take verifications. So if the county is requesting pay stubs or requesting any additional information, we have the ability to work with the patient in order to get that submitted to ensure that it is complete. The nice thing about this process is that majority of my team has eligibility background, so they're able to navigate that from a real experience in what is next for the patient as they go through that process. And so referring them to us is definitely helpful, as we also don't want to don't want to have a burden on the counties and having members going there or making phone calls, because we know that, as Thomas mentioned, the important work that they need to do is actually eligibility determinations and ensure that that's being done timely. And then finally, making sure that as the information in the toolkit is being shared, that the information is being disseminated to patients in your facilities. So providing flyers, providing contact information here is going to be key at your level to ensure that that message of retention is solid. Okay. This is an additional slide that we've included here that has the 800 number to our team, as well as the website that is located on IEHP that's specifically centered around renewal. We have shared this deck with Allison and team, so you will be able to have this for future reference. And so finally, what I wanted to spend some time actually walking through is how to check renewal status. So we talked a lot about messaging and communication and getting the word out through flyers and websites and social media. But what about at those access points when eligibility is actually being checked for the member, and what the provider portal within IEHP has to offer the provider community? So, you may or may not be familiar with this page, but this is the login to IEHP's provider portal, and it looks here. So once a individual actually logs in to the provider portal, the next section that they receive is a list of menu options. And so what they would do is they would click on eligibility. And it takes them to the screen that allows them to confirm eligibility for the patient at that time. Once the information for the patient appears, you will notice with the red arrow, there is an alert that will identify and send a message to the individual letting them know that the renewal is actually due. That's the opportunity to engage with the patient and just ask them, have they submitted their renewal, and providing them the contact information for IEHP if they haven't, so that way we can ensure that that is submitted timely. For our PCPs, we also have rosters in which we include on our provider portal that will allow you to see a roster of your patients in order to conduct outreach, or however that can be utilized into your workflow. So we've seen situations where some providers have done their own outreach in alignment with the work that IEHP and the counties are doing today, or also coming up with their own processes based upon that roster. And so I actually wanted to pass it back. This concludes our portion of the presentation. So Allison, I'll kick it back to you and you can talk through how we will navigate Q&A.
That's fantastic. Shalaun and Thomas, that was really comprehensive, so useful. Thank you, thank you. So I'm going to start really quick with, since I don't see any questions in the chat yet, please enter your questions, folks. But I'm going to ask two really quick questions here. First, Shalaun, you probably see Dr. Golshan's inquiry in here. Is there a way we can all get a copy of a link to the actual toolkit from IHP and HHS? Because not only would we like to make sure members know where they can find that through IHP, but we at SBCMS, RCMA, and all of the other partners on the line, I'm sure would like to be able to refer this access to the toolkit. So if you could send that to us, that'd be great.
Will do.
We really appreciate that. We will amplify this and help you disseminate this. Okay. So, Dr. Golshan, it's on the way. And I see Tyler Kinney has the same question. And then I also have a really, really quick question. And we may not be there yet, but the toolkit is hugely, hugely helpful. And I think that's a really good guideline for our providers and partners. One of the things that's being discussed, I know at the CMA level, is looking at legislation to increase some of the coding through HHS or through CMS rather to include, to offset administrative burden, which will be created for some of the physician practices. So, for instance, some of the administrative staff of the practices will need to focus a little bit more on communicating the points in the toolkit to the patients, checking, redetermination and things like that. And the proposal is that there may be some way to augment through some enhanced payments. Do you know anything about that, or have you guys been in any talks with anyone yet on that? Or are we not there yet?
Yeah. So Allison, on the coding side, we may have to bring a difference me to have a conversation about that. But
Yeah.
an element that related to that is this. Part of the work requirement or semi-annual review, there is a medical exception. So
Okay.
medical exemption is that the HCF is very committed that using the data from what we submit to the ACS, right? The code, the diagnosed code, to
Yeah.
proactively identify the member who are eligible for medical exemption, that they don't have to go through the work requirement or semi-annual report.
Okay.
So the code or diagnostic is super critical that we get all those corrected code, and the ACS will do that automation, that they will automatically screen out those individual that not doesn't have to go through that process. So your information is right on. But on the payments front, we will have to get back to you with for that.
Sure. And I know it's very early in the process still. We don't even quite know what all the changes are, especially with the pending status of ACA tax credits, which I think there's still some hope that we can recover some of those. So thank you guys for all your work on that. It's just amazing. So we'll see if there's a way to support some of the all of the physician practices in the administrative staffing side of an increased workload on some of this. So appreciate it. I don't see any other questions in our chat. Does anyone have any comments or questions right now that you'd like to ask verbally or raise your hand? I'm looking for that raise hand sign, guys. Can't believe it if we don't have any more questions. This is your chance, people.
Yeah, so I hope our presentation is clear or not confused more.
I think you must have answered all the questions because nobody has any. I think you guys did such a comprehensive job that it covered all the bases.
Yeah. So one thing, can I emphasize one thing that Shalaun covered
please.
there, Allison, that it is so super critical that every single IHP patient walk into your clinic, that making sure you check eligibility and see that alert and ask that member to renew or send that member to us. And we every day we are getting referral from you. And it's very effective because when you tell the patient what to do, oh yes, they will they will follow it really nicely. So we see a good volume, and we love to see that volume increase. Then that alert is live. We refresh the data every week. So the alert on those member that they not done yet, because if they already complete the process, they're gonna fall off. So if the alert's still there, that means they have to do something. They have to do something. So the data is very live. And we're fortunate to have that information that we need your help. We need your help. Send those patient to us or to the county. It doesn't have to be IHB only. They can call the eligible worker or submit the application. So appreciate
Okay,
that.
so it's really important that like you just said, that our providers though, make sure that the patients are in touch with you guys to solve this and to lock in their renewal or their redetermination. Okay, wonderful. I see we have a couple of questions. Yay. John Peranti, our good friend who is the CEO of Arrowhead Orthopedics. Hello, John. And John has a question. How much of the process can be automated using more AI tools to help control costs of processing all of this eligibility checking? Great question.
Yeah, that's a great question. And I was sitting in the work group with the ACS and the advocate, the plan, couple of us advocating for that automation. And the ACS very open because as we can see that when the whole PHE flexibility, it literally is enhanced automation. And when that happened, the auto renew is in 65, 70%. And the minute that flexibility is gone, the auto renewal rate now dropped down to only 40%. So now more eligibility requirement in place. So what can they do to automate? So for example, that the ACS have a record on member who getting IHSS hours, so services, the in-home support services. Those are qualify for medical exemption. So they're gonna tap into the data and automate to pre-screen those individuals out. And they have a way to automate as well as, for example, member report income. They may not report the number of hours. Remember, the work requirement is 80 hours a month, that including the training, the education, and the work. So they are looking to those agency and different things, try to automate that. So the member have less thing to do. So automation is the theme at the state discussion, and they just released a draft all county welfare director letter on the whole work requirement in the 6 months. And there's a huge statement in there that they will do the most to automate the process to control the cost as well as the convenience to make sure the right people are still on the Medi-Cal. Great question.
Well, that's good to know they're open-minded to utilizing that as a resource, as a tool and a mechanism to make this easier for everybody and increase the number of enrollees. I mean, that's what we want. We don't want to see them decrease. Okay, thank you, John. Erica Lopez has a question. Any changes for newborn gateway, children with duplicate IEHP IDs and CINs?
Oh, wow. So this is the right time so Shalaun can share. We just had two critical meetings with the ACS and one with the county. And I can share with the ACS and Shalaun can share the work with the county now on the whole newborn gateway program. What we identify in the newborn gateway program is that, at the state, moving to that development, there's some, I would call some unintended, I have to say, they are admitted, it's unintended miss that they have in the program. So some unintended miss, including that when the when the newborn enrolled through the hospital newborn gateway program, that it generates the SIN number for that newborn. However, when the system set up, when the data sent into the health plan, there's no linkage to the mom. And as we know that the newborn coverage is the month off and the month after to the mom coverage. And without the linkage to the mom coverage, it prevents the health plan from processing the claim or provide coverage to the newborn, right? So that's more the system issue that they couldn't connect the SIN number of the newborn to the Medi-Cal mom. That's one issue. The other issue is this: the newborn enroll in the gateway program, the hospital, the HPA gateway program, sometimes to the non-Medi-Cal mom. So the system somehow it processes, but there's a that when that but when that record get processed, it get transferred to the county, and at that time, the county will start working on the Medi-Cal application for that newborn. So there's a discrepancy between for those scenarios. There's discrepancy between the active date for the newborn, then the reality of the actual enrollment date for the newborn. So the third one that they found, because thank you for your this all the feedback we get from the provider community, and we get feedback from our friend at ARMC that share with us. Um, the third scenario is that we start seeing the newborn with many UAS flag. We said, wait a minute, the newborn were born at LMC, they born at our hospital. Why they have a flag at undocumented? So there is the deficiency in the system is that because we saw it, we saw like 2024, we only have what 200. Don't quote me on it. It's about 100 to 200. But then 2025, we see that in thousands. And we check every single claim of that morning. We know those newborn were born here in our hospital network, unless of them change up there that we don't know, right? You never know. But they look into the system and they identify that because there's no indicator in that newborn enrollment program for the county, for the hospital to put it in like UAS or non-UAS or SIS, right? So when data go into the main data source, without that indicator, it defaults to UIS. So that's why we see the significant increase of the newborn with UIS flag in the system, because there's no record coming from the gateway. So when that record go into the main Medi-Cal eligibility, the hub, without the record, the system default them at the UIS. So if they don't see the record, they're going to default them. And that's the problem is the statewide. So those kind of things. So they commit to work on those issue and on the priority list. And we just need a that could be a fun question when you ask in the Siri when the research. The phone recorded the research. Teresa, my friend at DXL, and she can help answer though. But DXL is committed to fix the issue. So Shalaun, can you share about our meeting with the county on the whole duplicate ID and SIN for the newborn?
Um, yes. In that conversation and all of those learnings from DHCS, we did have an opportunity to speak with our counties, and just getting an understanding from the operational side, what it is they're seeing when that information is being transmitted over to them from the newborn gateway. And so we actually did a crosswalk of several examples of the duplicate SIN issue, Erica, that you're actually referring to. So, number one, happy to report that our counties are committed to helping us resolve our duplicate SIN issue. We are sending, as you know, Thomas was talking about, one, the great relationship, but the data sharing that we do. We are sending over monthly those newborns that we're identifying with the duplicate SINs in order for them to be corrected. So that's number one. But also getting to the root cause of where the duplicate SINs are occurring. Is it something at the entry point of the application in the hospitals? And so we are identifying where this actual issue is occurring. So that way, if it's happening at the point of the application process, through the newborn gateway, that we can work with those hospitals specifically, understanding their workflow, and also providing them a little, toolkit or some messaging or a reference point for them to guide them through that process. Also, just making sure that we are also clear, because when newborns are not eligible through Newborn Gateway for whatever reason, making sure that there is a clear understanding of the pathway of the other presumptive eligibility through the children's presumptive eligibility that those newborns may be entitled to. So that's some of the work that we're doing on the eligibility side and operationally to address the duplicate sin and the ID issue.
Wonderful. Yeah, because that could really, really throw the numbers off, right? That's amazing. Okay, very helpful. Well, folks, I'm not seeing any other questions. Unless I'm missing it, I'm not seeing any other raised hands. So, oh, there's one. Thank you, Erica. What about record of deceased patients?
That's another great one. You know, Erica, you picked the right folks in this room today to answer these questions. But in terms of deceased members, as well as we have a data exchange with the county as well to identify those members as we are made aware of those deceased records. So we are sending that over to the county, and unfortunately, they just can't take, our word for it that a member is deceased. There is a process, an eligibility process that they have to go through before they can say they are going to disenroll the member because they are deceased. So the important work for us is to get that information over to the counties timely, which we do on a monthly basis, and then allow them to follow up and do their eligibility processing to disenroll the member from the program.
Great. Does that help, Erica? Hope that answered it. Sounds like it certainly did. All right. Somewhat. Thank you, Erica said. Do you have you want to say anything, Erica? Or are you good? Okay. Well, okay, folks, I guess that we can go ahead and wrap it up and give you 15 minutes back of your day. That again was so comprehensive and just so incredibly helpful and clear. We want to thank Thomas Pham and Shalaun Jones with IEHP for not only helping us put this entire series together, but being our star presenters today. We told Thomas and Shalaun they're our VIPs for sure. So we thank you guys so much for all the work you're doing in this. Oh, one more. Can we get a contact to send death certificates?
I will figure out what the process is, Erica, and make sure I get that back to you. I don't know if it's death certificates specifically that we need, but I will make sure that we get a communication or a contact or what that workflow looks like for communication.
Erica, why don't you pop your email real quickly into the chat so Shalaun has that. I mean, we'll send you the slides as well with Shalaun's information, but we want to make sure that that's here for her to readily have accessible. Okay, everyone. Well, be sure you tune in for our next session next month, and that is going to be on January 14th, Medi-Cal enrollment and physician offices action steps so you don't get left behind. So this will be in the context of additional updates that are coming forward since it's going to be the start of 2026, the new year, and you saw Thomas's timelines on this. This is with Teresa Hasbrock with the Medi-Cal Eligibility Division, Department of Healthcare Services, DHCS. And Thomas mentioned her as a partner that I know you guys work really closely with, Thomas and Shalaun. So Janice has put the registration info here in the chat, and we hope you guys get signed up for this. It's on our website as well, sbcms.org/events, sbcms.org/events. And we'll send out the recording and the slides, and we will amplify the toolkit. And we thank you all so much and wish you just amazing holiday season. And thank you all. Hang in there. And there's always there's always work being done and always solutions that we are seeking to. Let's stick together to, continually make things better and mitigate any negativity that comes out of policy changes. Thank you all. Have a lovely rest of your week. And Thomas and Shalaun, thanks again.
All
See you
right.
guys
Thank you.
soon. Okay. Bye.